Hello, Medicos. Good day to all of you. This is Dr. BK for you, and today I will be starting with the ear or the auditory cavity. So, the ear again I will be discussing under two lectures. So, in the first part of the ear for today's session, so we will have a short introduction about the auditory cavity, and followed by that we will actually learn the external features and parts of the pinna, its nerve supply and blood supply. Then followed by that we will also understand the features and the clinical aspects of the external auditory meatus or external acoustic meatus, and then followed by that we will actually start with the middle ear. So its boundaries and features of the middle ear, and in the middle ear also we will cover briefly uh, the features and the tympanic membrane and the auditory tube. Now first, starting with the ear, it is an organ of, or it is a sense organ, because it is the organ of hearing, and followed by that it is also an organ of equilibrium. So mainly it actually receives the sound, and then these sound waves are actually converted into the nerve stimulus, and that stimulus is carried by the eighth cranial nerve or the vestibulocochlear nerve to the brain. Okay, and mainly to the brainstem, and from there it is projected to the cerebrum, where we have the auditory area. So there we can actually recognize various sounds, and not only various sounds, we can also actually recognize whether it is a sound which we have already heard. So that is how you recognize a voice which you are familiar with or not familiar with. Okay, so it is a bit complex. Now we will pass on to the auditory cavity. So mainly your ear as a whole consists of three parts. One is actually called as the external ear, which is mainly concerned with the collection of the sound waves. Okay, and then you have the middle ear or the tympanic cavity. Okay, so that middle ear or tympanic cavity is mainly consisting of these ear ossicles. So the main function of these air ossicles is, through this movement, it increases the force of vibration, okay, without altering the amplitude. Okay, so through that it is actually transmitted to the internal ear. Okay, so this is actually the internal ear, which consists the peripheral organ of hearing, that is the organ of corti, and these are mainly concerned with your equilibrium, that is your static as well as the kinetic equilibrium. Okay, so from the here these vibrations, why it is intensified here is because here they have to travel through a fluid membrane. Okay, and then this sound vibrations or the physical energy will be converted into nerve stimulus, which is carried by your vestibular and cochlear nerve to the brain. Okay, now if you look at the external here, first we are going to start with the external here. It is somewhat trumpet shaped. So like a trumpet, it has got a long tube and with the wide end. Okay, that is mainly for the collection of the sound waves, and then this is mainly collecting the sound waves, and then it conducts the sound waves, which is actually received by the tympanic membrane or the eardrum, which you see here. Now first, coming to the external here, you are able to see this has got two parts. One is the auricle or the pinna, and then you have a short canal which is called as the external auditory meatus. Okay, so the auricular pinna is actually a single piece of elastic cartilage. Okay, it is a single piece of elastic cartilage, and the lower part here, the elastic cartilage is absent, and mainly this part, the lobule of the here, where the cartilage is absent, you have only the fibrofatty tissue, and the whole of the cartilage with the fibrofatty tissue is actually covered by the skin, and the skin is tightly adherent to the underlying cartilage. Now, this cartilage is continuous with the external auditory meatus, because the external auditory meatus is also partly cartilaginous, and then what happens is it is partly bony. Okay, so it has got a lateral surface which you are able to see here, and then it has got a medial, some books considered also it has the cranial surface. Now, let us try to understand the parts of the pinna or the auricle. So mainly you see a depression that is called as the concha. Okay, so this is mainly called as the concha, and then the periphery of the pinna or the cartilage, you have a peripheral cartilaginous rim which is called as the helix. Okay, so that is actually called as the helix. Now the helix, what happens is enters into the concha as the crux of the helix. Thereby, it divides the concha into the lower large space is called as the concha, and the upper space small area is actually called as the Simba concha. Okay, as I told you, the concha leads into the external auditory meatus. Okay, it is guarded again by a small fold of cartilage which is called as the tragus. Okay, and the tragus, opposite the tragus, you have the antitragus, and these both are separated by the intertragic notch. Tragus, antitragus, and the intertragic notch. Okay, in front of the helix, you see another posterior part. You see parallel to the front of the helix another elevation which is called as the antihelix. So that also what happens as it passes above, it forms the crux which splits to enclose a small area that is actually called as the triangular fossa. And the depression which you see between the helix and the antihelix, this depressed area is actually called as the scaphoid fossa. Okay, so that is actually called as the scaphoid fossa. Okay, so these are the parts of the uh, pinna, and actually the skin is richly supplied with sebaceous glands, and also you have the sweat glands, and distribution of hair over the pinna is actually a trait of Y-linked genes, or you call it as the Hollandric genes, which is expressed only in males, not in all males, that also in certain males. And in the helix sometimes you will be able to see a tubercle which is actually called as the Darwin's tubercle. Okay, so that is also mainly is a genetic in appearance, because it is not seen in everyone's, only when certain genes are expressed then you will be able to see that. Then of course the pinna is used for piercing the lobule of the ear, so where the earrings are actually pierced most commonly. And there are also other theories with respect to pinna, because it represents like a fetus, and there are various pressure points on the pinna. Okay, so which what happens, the whole body can be stimulated, all the viscera, internal viscera or parts are actually represented on the pinna. So certain pressure points are there where you can actually activate those organs, but all this is not proved medically. These are all various theories, but with respect to the allopathic medicine, there is no proof or evidence to such claims. Okay, so that is about the parts of the external here, and Deep to the skin, you are able to see there are also muscles which are actually attaching to the auricle. They are actually called as the auricularis superior, anterior, and posterior. So these muscles come under the muscles of the facial expression. So auricularis superior and anterior, they actually originate from the epicranial aponeurosis, and posterior is actually from the squamous part of the temporal bone. So they mainly insert into the auricle deep to the skin, and they are mainly supplied by the branches of facial nerve, especially the auricularis anterior and superior will be supplied by the temporal branch of the facial nerve, and posterior will be supplied by the posterior auricular branch of the facial nerve. They move the auricle as a whole. These extrinsic muscles, the auricularis anterior, posterior, and superior, they move the auricle as a whole, and especially this is vestigial in case of the humans. In lower animals, and the very best example is the in the elephants, you can see how they move the ears because through these muscles. And there are also intrinsic muscles, very short intrinsic muscles, which you call it as helicis major, helicis minor, and so on. These intrinsic muscles alter the shape of the pinna. Okay, so these intrinsic muscles alter the, as I told you, the shape of the pinna. So the skin is actually very firmly adhered to the underlying cartilage. You are able to see here. So there is very minimal fat here, except for the lobule of the ear, and it has got lot of sebaceous glands, as I told you. Next, the innervation of the external ear or the pinna is mainly by the uh, auriculotemporal nerve, which supplies your lateral surface. So this is the lateral surface which is supplied by the auriculotemporal nerve. Okay, and then it is also mainly supplied by the auricular branch of vagus nerve, especially the concha part is supplied by the auricular branch of the vagus nerve. The lower lateral part is mainly supplied by the great auricular nerve. And one more nerve which supplies is the lesser occipital nerve, which supplies the medial surface or the cranial surface. Okay, so these are the nerves which are mainly supplying great auricular nerve, auriculotemporal nerve, lesser occipital nerve, and then the auricular branch of the vagus nerve. The auricular branch of vagus nerve is also called as the Alderman's nerve. So I will come to the details of this, why it is called as Alderman's nerve, in a couple of slides. Okay. So now with the details of this external or ear, mainly the auricle or the pinna, now we will move on to the external auditory meatus. So the external auditory meatus is actually a canal, or it can also be called as a canal, which is partly cartilaginous and then it is actually partly bony, and it is definitely lined by skin, and it is not a straight canal, it is S-shaped. Okay, so mainly what happens is the first part mainly runs upwards medially, and what you call upwards medially and then backwards, and then the middle part again run upwards medially and forwards, and then it runs medially and downwards. Okay, the whole length of the canal is around 24 millimeter or roughly 2.5 centimeters, whereas the lateral cartilaginous part is only 1/3 and the medial part is actually 2/3, which is bony. The bony part is mainly formed by the tympanic plate of temporal bone. So that is the temporal bone, no, which you are able to see here. Styloid process and the mastoid process you are able to see. So the tympanic plate of temporal bone mainly forms the majority of the bony part of the canal, and posteriorly it will be also formed by the squamous part of the uh, temporal bone. Okay, so as I told you, it's an S-shaped passage, and in children what happens is this bony part is not well developed, it is still growing and unossified. So when you want to insert a speculum, you should be very careful and keep it in mind because of the shortness of this canal. Okay, because of the shortness of this canal, while introducing a speculum, and because very soon you will be reaching the medial end, and if you are not careful enough, the speculum might damage the tympanic membrane. So as I told you, the canal is S-shaped. When you want to view the tympanic membrane, you have to pull the auricle upwards, then backwards and laterally, so that you straighten the tube, and you will be able to visualize the tympanic membrane. So at the medial most end, what you see is the tympanic membrane, which is also obliquely placed. So because of this oblique placement, you will be able to see the floor is actually longer and the anterior wall is longer than the roof and the posterior wall. So the posterior wall and roof is shorter, whereas the floor and the anterior wall is longer because of this obliquely placed tympanic membrane. So which is around making an angle of around 55 degrees, okay, to the horizontal plane. Okay, so now coming to the internal lining, it is mainly lined by the skin. So again, the skin which is lining the external auditory meatus. The pinna also lines the skin, and you see a lot of modified sebaceous glands, and that glands are actually called as the ceruminous glands. Okay, mainly seen in the, what do you call, uh, the cartilaginous part. So this skin is again tightly adherent to the underlying cartilage and the bone, and the bony part of the skin is somewhat thin compared to the cartilaginous part. So the wax secretions of these wax glands, ceruminous glands, produces the ear wax. Okay, now this is mainly necessary, these secretions, to create a humid atmosphere, a warm humid atmosphere for mainly easy conduction of the sound waves. Then second thing is actually any insects also, because of this humid what do you call, because of this humid environment, it actually hesitates to enter, but of course insects sometimes they enter. And the third one, the main function is any water gets trapped inside it. So naturally it prevents the skin from getting macerated or damaged. So this is the main function. And since the skin is actually very tightly adhered, any wounds or boils or exudate of the infections, they are not dangerous, but they are extremely painful, because these collection or exudate, what happens is, will not be able to expand, and it stretches the skin too much. So that is why it is very painful. Then coming to the arterial supply, it is mainly supplied by branches from the posterior auricular artery, and also branches from the anterior auricular, which is a branch from the superficial temporal artery. Okay, so posterior auricular and then anterior auricular branches from the superficial temporal artery. Then you also have branches mainly from the maxillary artery. So you see the deep auricular. So mainly the deep auricular artery, which is from the first part, also supplies your external acoustic meatus, which you are able to see here. The bony part, the cartilage is here. This is mainly your immediately above the external auditory meatus. Okay, that is the cartilage, is the bony part formed by the tympanic plate of the temporal bone, which you are seeing here. Okay, so posterior auricular, deep auricular, and anterior auricular branches. With respect to the nerve supply, external auditory meatus is mainly supplied by the auriculotemporal nerve. Okay, the roof and the anterior wall is mainly supplied by the auriculotemporal nerve, and the next nerve which is supplying it is the auricular branch of the vagus nerve. The floor and the posterior wall is mainly supplied by the auricular branch of the vagus nerve. And it is some authors claim that the fibers of the facial nerve actually travel via this auricular branch of the vagus nerve. So they believe that the the facial nerve also has some sensory component. Okay, so coming to the clinical aspects of the external ear, collection of the earwax. So if too much of earwax is actually what do you call trapped inside the ear, then naturally what happens, it blocks the external auditory meatus. So same time what happens is your hearing is definitely impaired, and earwax can also produce pain if it is impacting your external auditory meatus. So this is actually removed by syringing with method, you call it as syringing of because if the earwax has hardened, then naturally you have to what do you call, you have to actually uh, inject hot water through force, and only then the impacted earwax will come out. And as I told you, the warm water is used because if you use cold water, then naturally it might stimulate your auricular branch of vagus nerve, and that might actually what happens is lead to coughing or vomiting, which is most commonly seen in the elderly patients. Okay, and if it is stimulated too much, the auricular branch of vagus nerve, so it is a branch of vagus nerve, the vagus nerve gets stimulated, which is parasympathetic to the heart, so it will decrease the heart rate, and sometimes in very rare cases even heart failure can occur. Okay, and then mild stimulation sometimes increases the appetite, so that is why it is actually called as the alderman's law, because these alderman are group of people which are seen in the ancient time. So they used to actually inject mild cold water into this ear so that to increase their appetite. Okay, so that is why it is called as the alderman's nerve, which I have mentioned in the last slide. Then referred pain from your tooth, caries tooth, and also cancers of the tongue might be referred to the ear through the mandibular branch of the trigeminal nerve. So mainly your auriculotemporal nerve, which is a branch of the mandibular nerve. So that might carry your referred pain from the tooth, okay, and the cancers of the tongue. So that is about the external auditory meatus. Now we will actually pass on to the middle ear, or also called as the tympanic cavity. So the middle ear or tympanic cavity, if you look at it, it is mainly present within the petrous part of the temporal bone. So both the middle ear as well as the internal ear, they are situated within the petrous part of the temporal bone. Okay, the temporal bone has got four parts. Mainly you see the petrous part, then you see the squamous part, then you have the tympanic plate of the temporal bone, and then you have the mastoid part of the temporal bone. The petrous is very hard, and it is ivory. It is very hard like an ivory. That is why the name petrous. Okay, so if you look at the middle ear cavity, the shape is like a biconcave lens. So like your RBC. Okay, like an RBC, because the lateral wall and medial wall, they are actually compressed, and only the superior and inferior is somewhat wide. So that means in the middle what happens, it is very narrow and sandwiched between your external auditory meatus, because the tympanic membrane is projecting inwards, so that reduces the space laterally. And you see the promontory, the basal turn of the cochlea is projecting into the medial wall, so thereby the middle is like a compressed, and that is why it is actually biconcave in appearance. So it is separated from the external auditory meatus by the tympanic membrane, and anteriorly it communicates with the nasopharynx through the auditory tube. Same way posteriorly also it communicates to the mastoid air cells through an opening which is called as the additus to mastoid antrum. Okay, so it communicates with the mastoid antrum through Auditory to mastoid antrum. These are the two communications with the anteriorly with the auditory tube and posteriorly with the mastoid air cells. So now we will just try to understand the features of the middle ear cavity. So now you are able to see the middle ear cavity which is open. That is your lateral wall, that is your medial wall, that is your floor, and here what you are able to see, sorry, this is your roof, and here you are able to see the mainly the floor. Okay, and four walls you are able to see. So the medial wall has been opened. So you are actually looking it from the medial, excuse me, you are actually viewing from the medial aspect. Okay, and then the posterior wall, you are able to see that adheres to the mastoid antrum. So that side is your posterior wall. Okay, this is your lateral, medial, posterior, and the anterior wall has been cut open and removed. So mainly it consists of three ear ossicles you are able to see here. That is the malleus, and that is the incus, and that is the stapes. So we will see in detail about these ear ossicles in the second part of the ear lecture. And two muscles. One muscle is the, you are able to see here, the tensor tympani muscle, which actually tenses the tympanic membrane. Okay, vibrates the tympanic membrane. The other one is actually the stapedius muscle. So that stapedius muscle, what happens is it's attached to the foot plate of the stapes bone. Then, so these are mainly the contents of the middle ear. Three ear ossicles you are able to see, and two muscles, tensor tympani and stapedius, and nerves. You come across, this is the tympanic branch of glossopharyngeal nerve, and this will form the tympanic plexus along with the caroticotympanic nerves. They are sympathetic nerves. Okay, so, and then the tympanic plexus has got a sympathetic component, and the tympanic branch is a glossopharyngeal nerve is a parasympathetic component. So from this tympanic plexus, what comes out of this roof is the lesser petrosal nerve. So you should by now recollect what is lesser petrosal nerve. It is the preganglionic parasympathetic fibers to the parotid gland, so to the otic ganglion. Okay, so tympanic plexus, caroticotympanic nerve, and one nerve which is crossing medial to the handle of malleus, that is your cauda tympani nerve. That again carries preganglionic parasympathetic fibers to the otic ganglia, sorry, to the submandibular gland, and also it carries the taste sensations from the anterior two-third of the tongue. Then, of course, some books consider facial nerve also, which is seen in the facial canal. So, through the medial wall and also through the posterior wall, the facial canal makes an impression inside which the facial nerve is present. Then you have six set of arteries which is supplying the middle ear, and then you have the ligaments. So mainly these ligaments you are able to see here of the incus malleus, the anterior ligament of malleus are present, and all this is actually lined by uh, the mucous membrane. So this is all external to the mucous membrane. So deep to the mucous membrane, mainly you have, it is filled with air, which is a genuine content. So this air actually comes via the auditory tube. This air actually comes from the auditory tube. Okay. Then so the ear ossicles assume full size at birth. So when during the birth itself, what happens is there is no, they have attained their adult size. So now coming to the middle ear, uh, this representation is actually like a cubicle, roughly cubicle in shape, which is purely diagrammatic purpose and for the sake of our understanding. Okay, so the middle ear can be divided into three parts: epitympanum or epitympanic recess, which is actually what do you call, somewhat an extension on the roof. Okay, which extends above the tympanic membrane at most widest part. Okay, So that will be around 6 mm diameter. Then you have the mesotympanum, the most what do you call, the narrowest part, because as I told you, you are able to see the tympanic membrane is bulging and also the promontory is bulging. So it is only 2 mm in nature. And then what you see here is below the tympanic membrane is the hypotympanum, which is almost 4 mm, 4 millimeters. Okay, so epitympanum or epitympanic recess, mesotympanum opposite the tympanic membrane, and then what you have is the hypotympanum. So roughly you can actually extrapolate it to the cube, which has got a 6 walls, which you are able to see. 5 walls you are able to see here. That is the lateral wall, and this is the medial wall, and that should be your roof, and this should be your floor, and that is your posterior wall. The anterior wall is actually cut open. Okay, so the roof is somewhat what you call bulged outwards and called as the epitympanic recess. The epitympanic recess mainly contains your head and your short process of the malleus, and then you have the incus. Both the short process of long process of incus is also seen mainly in the epitympanic recess. So first coming to the roof, floor, and then you have the lateral wall, medial wall, anterior wall and posterior wall. So you have these 6 walls for the middle ear cavity. So that is why it is roughly cubical in shape. Now coming to the roof, it is also called as the tegmental wall. So it is mainly formed by tegment tympani, a thin plate of a bone, and this bone is also continuous and forms the roof for the mastoid antrum. The roof is continuous as the roof of the mastoid antrum. So this tegmental wall separates your middle ear cavity from the middle cranial fossa above. So above you have the middle cranial fossa. It is a very thin bone, and in children especially this bone is not ossified. Okay, so you are able to see the mastoid air cells, and that is the roof which is mainly formed by the tegment tympani. So one more, if you take a section along the petromastoid part, it actually appears like a piston. Your middle ear cavity with its mastoid air cells posteriorly and the auditory tube anteriorly. Okay, so as I told you, it also forms the tegment tympani, the roof of the mastoid antrum. Okay, and this wall in children is not ossified, it is still membranous. Okay, so there is very what do you call, chance of the any infections of the middle ear through the roof might also pass on to the middle cranial fossa, and it might also spread to the meninges, leading to inflammation of the meninges, are also called as the uh, meningitis. Okay, so that is the tegment tympani, and the tegment tympani also has two small openings for the greater and the lesser petrosal nerve, the greater petrosal nerve and the lesser petrosal nerve. So the lesser petrosal nerve from the tympanic plexus through the roof it comes, and then it will descend through the foramen ovale. Greater petrosal nerve is actually from the facial nerve, also traverses the roof, and it is going to enter the pterygoid canal, which will join with the nerve of the which will join with the deep petrosal nerve to form the nerve of the pterygoid canal. Okay, so veins through the roof also they pierce and they drain into the superior petrosal sinus. So this is again one way of again spread of infections from the middle ear to the middle cranial fossa. So that is about the roof. Okay, so here you are able to see the roof is actually pierced by the lesser and greater petrosal vessels and the nerves. So from the tympanic plexus, the lesser petrosal nerve comes and it will enter into the foramen ovale. The greater petrosal nerve, as I told you, will enter your pterygoid canal. The next boundary or wall, what you are able to see here is the floor of the middle ear cavity. It is also called as the jugular wall because it is related to the superior bulb of internal jugular vein. And again, there is very thin bone separating the floor from the jugular fossa. Sometimes this bone is also absent and it is only the mucous membrane which separates the internal jugular fossa, and mucus and a fibrous membrane separates the floor from the internal uh, superior bulb of the internal jugular vein. Now, if you look at the floor more anteriorly at the junction between the jugular fossa, okay, and the anterior wall somewhere, you see an opening which is called as the tympanic canaliculus. So that is through which the tympanic branch of the glossopharyngeal nerve enters. So the tympanic branch of the glossopharyngeal nerve enters through a small tympanic canaliculus which you see on the floor, and then it will ramify over the promontory to form the tympanic plexus. So tympanic branch of glossopharyngeal nerve and the caroticotympanic nerves will join the plexus in the formation of the plexus. Okay, so that tympanic canaliculus you are able to see between the jugular fossa and the lower part of the carotid canal. So it is given as canal, actually it is a carotid canal. You are able to see that this is the lower opening of the carotid canal. The upper opening of the carotid canal is anteriorly, and that will be the posterior end of your foramen lacerum. So this is the posterior end of the foramen lacerum which you are able to see here, the upper opening of the carotid canal. So it is also surrounded by carotico, you are able to see that is the sympathetic plexus surrounding the internal carotid artery. From that only the caroticotympanic nerves they enter through the anterior wall. So floor is jugular wall, internal jugular vein is related to it, and you have the tympanic canaliculus for the tympanic branch of the glossopharyngeal nerve. The next wall which you are going to see is the lateral wall. So you are able to see the tympanic branch of glossopharyngeal nerve entering through the floor. So the lateral wall is mainly formed by the tympanic membrane. Okay, so the membrane is actually attached to a sulcus on the tympanic plate of temporal bone, which is called as the tympanic sulcus. And medial to the tympanic membrane, you are able to see the handle of Malleus is attached at the maximum point of convexity. So that is the handle of Malleus, and that should be your head of Malleus, and that should be your anterior process of Malleus. So the handle of Malleus is attached to the medial surface. And medial to the handle of Malleus, you are able to see the cauda tympani nerve is actually crossing. It enters the middle ear mainly through the posterior canaliculus. So from the facial nerve, which is seen in the posterior wall, posterior canaliculus, this is facial nerve in the facial canal. Then it passes medial to the handle of Malleus, lateral to the incus, and leaves the middle ear cavity through the uh, anterior canaliculus, which is situated in the medial end of petrotympanic fissure. Okay, so petrotympanic fissure is actually petrosquamous, which can be divided by the tegment tympani into squamotympanic fissure divided by the tegment tympani into petrosquamous and petrotympanic fissure. So through the posterior canaliculus, it enters, passes near the lateral wall medial to the handle of Malleus, and then leaves the middle ear cavity through the anterior canaliculus, which is situated at the medial end of the petrotympanic fissure. So then the tympanic membrane, it is in a layman's term, it is actually called as the eardrum. It is actually obliquely situated at an angle of 55 degrees, and that is why, as I already told you, the floor and the anterior wall is longer than the roof and the posterior wall of the external auditory meatus. This membrane separates your external auditory meatus from the middle ear cavity. Okay, so it is actually facing laterally downwards and forwards. So it is facing downwards, so because it is facilitating to collect the sound vibrations even from the lower part of the floor as we walk, to collect also sounds from the floor level. So as we move, Okay, so as I told you, this is the reason for the lengthiness of the mainly your anterior wall and the floor of the external auditory meatus. So if you look at the tympanic membrane, it is somewhat slate gray in appearance, and it is attached to the tympanic sulcus. It is attached to the tympanic sulcus, and here you are able to see a wide depression. From that you are able to see two folds, they descend, mucus folds, thereby dividing the tympanic membrane into pars tensa, which is very rigid and tight, and the other one, which is somewhat lax, is actually called as the pars flaccida. So the anterior margins are thickened, as I told you, which attaches to the tympanic sulcus. As the thickened margin is actually called as the annulus or the tympanic ring. Okay, so from the upper part of the tympanic ring, two mucus folds, they actually called as the anterior and posterior malleolar folds. Okay, so anterior and posterior malleolar folds attaches to the lateral process or the anterior process of the malleus. This is the handle of malleus. Okay, so the handle of malleus is actually attached to the inner part of the pars tensa, and that produces the maximum convexity called as the umbo. The pars flaccida, or the lax part, is actually present between the two malleolar folds. The remaining part is actually called as the pars tensa. So that is umbo, where the handle of malleus is attached, which produces the maximum convexity. So it is convex medially, whereas it is concave laterally. Okay, so it is concave laterally and convex medially because of the pull of the handle of malleus. Okay, so when the mucous membrane is illuminated, you are able to see a cone of light on the anterior inferior part. Okay, so you are able to see the cone of light, the anterior inferior part, and there you will also be able to see a somewhat slight yellow projection, which is the handle of malleus, and deep to that handle of malleus the cauda tympanic nerve is actually um, passing. So you see a cone of light mainly in the anterior inferior part or quadrant of the tympanic membrane. Okay, if you look at the tympanic membrane, externally it is actually covered by skin, and the middle you have the fibrous layer, and internally it is covered by the mucous membrane. So there is some recesses between the handle of malleus and the remaining part of the tympanic membrane. Okay, same way there is another recess between the anterior process and the tympanic membrane, which is also called as the Prosax pouch. So these are all the mucous recesses which you see on the medial surface of the tympanic membrane. Okay, so externally it is actually covered by skin, and deep to the skin you have fibers which are arranged radially. Okay, you are able to see circular fibers as well as the radial fibers, and skin actually it is lined by stratified squamous epithelium. These fibers are absent in the pars tensa part, so that is why it is somewhat lax, and internally it is actually the mucous membrane covering, and that is actually lined by the columnar epithelium. So skin is an ectodermal derivative, and this fibers medial middle part is actually a mesodermal derivative, and the mucous membrane is actually endodermal derivative. So the tympanic membrane is one such what do you call structure which is derived from all the three germ layers. So blood supply, deep auricular and anterior tympanic branches from the first part of maxillary artery, and you also have a posterior tympanic artery which is from the stylomastoid artery. So nerve supply, medial surface will be supplied by the tympanic branch, no? Glossopharyngeal from the tympanic plexus. Lateral surface will be supplied by the auriculotemporal and auricular branch of the vagus nerve. So medially I told you the tympanic branch, and laterally by the auriculotemporal and the Alderman's nerve, auricular branch of the vagus nerve. So applied anatomy. So mainly what happens is tympanic membrane sometimes might get ruptured, or in otitis media, if there is collection of pus, there will be tremendous pain to drain the pus if it is not actually receding through antibiotics or oral medications. You have to drain the pus by creating a small nick, okay, but excluding the anterior inferior part. Otherwise you will damage the chorda tympani nerve. So you make a small nick and drain the pus, and that procedure is actually called as meningotomy. Otherwise what happens sometimes, the tympanic membrane itself might rupture. So perforations can occur in the tympanic membrane because the pus might point anywhere due to pressure and it might open, or due to trauma. So that is why you are not supposed to put any sharp objects or earbuds. You might accidentally damage the tympanic membrane, which might produce perforations. And the ear wax also, when you try to push use the earbud, you are pushing the wax more interiorly. So if the tympanic membrane is ruptured, then what happens? It might interfere with their hearing. Okay, so tympanoplasty. So the ruptured tympanic membrane, what happens? They take a tissue from the other surface anywhere else, and then they do a grafting, and that procedure is actually called as the tympanoplasty. So we finished with the roof, floor, and lateral wall. Now we will come to the anterior wall. So which you are able to see here are also called as the carotid wall, because it is related to the carotid canal. So the wall is actually narrow, and the lower part of the wall separates the middle ear cavity from the internal carotid artery. So two openings you are able to see here. One is actually the opening of the auditory tube, and other one is for the canal of the tensor tympani muscle. Okay, so here you're able to see the opening of the auditory tube, and above that you see a small canal for the tensor tympani muscle. Both are separated by a very thin plate of bone, and that canal for tensor tympani, what happens? Bone again forms a hook-shaped process which is called as the processus cochleariformis. Okay, so through the canal for the tensor tympani muscle enters, and the tendon of tensor tympani will actually play around the processus cochleariformis and gets inserted into the malleus. Okay, so that is the thin plate of bone between the auditory tube and the canal for tensor tympani, which will turn medially as the processus cochleariformis. So that is the processus cochleariformis you are able to see here. Then other one is you are able to see is the opening of the auditory tube. The tendon of the tensor tympani will actually wind over this and then come and get inserted into the malleus. So in the anterior wall also you have the opening for the caroticotympanic nerves. Okay. So the opening of the caroticotympanic nerves you also have. So these caroticotympanic nerves, what happens is they will actually take part in the tympanic plexus along with the tympanic branch of glossopharyngeal nerve. So next, coming to the auditory tube, since it is situated in the anterior wall, also called as the eustachian tube. Again, it is an osseo-cartilaginous canal, partly cartilaginous. The lateral part and the medial part is osseous. So almost 3.6 centimeters in length, of which it connects the lateral wall, that is the nasopharynx, with the middle ear cavity. So mainly for equilibrium of the pressure on either sides of the tympanic membrane. That is the main function of the auditory tube. So the cartilaginous part is 2/3 in length, whereas the osseous part is only 1/3 in length, and lined by ciliated columnar epithelium. So the bony part actually extends from the anterior wall. So, okay, and to the junction of the petrous and squamous part of temporal bone. Okay, between the petrous and the squamous part of temporal bone, up to that is the part. Coming to the cartilaginous part, it is almost 2.4 centimeters or 24 mm, forming the 2/3, and you are able to see it is a single cartilage which is folded hook-like. So you have a broad medial lamina and a short lateral lamina, and it is incomplete, does not form a complete lumen, and that part is actually covered again by a membrane, fibrous membrane. Okay, so mainly the posterior inferior part will be covered by the fibrous membrane, so below and laterally. Okay, so that is the below posterior, and laterally it is covered by the fibrous membrane. So single sheet which is bent like a hook, which has got a broad medial lamina and a short lateral lamina, the cartilaginous part. The junction of the cartilaginous part and the bony part again is narrowed. It's called as the isthmus, and it lies in the sulcus tubae on the under surface of the skull, norma basalis, at the junction of the petrous part and the greater wing of sphenoid. There it is lodged in the sulcus, which is called as the sulcus tubae. The muscles which are attached mainly is the tensor tympani muscle, which you are able to see here from the medial lamina. Okay, that is the tensor tympani muscle, which you are able to see from the medial lamina. Then the levator veli palatini muscle. Okay, so for the elevation of the palate, again it arises from the cartilaginous part of auditory tube. And one more muscle is a salpingopharyngeus, which is will be attached to your around the tubal elevation, which we see on the lateral wall of the nasopharynx. Okay, so mainly three muscles. Okay, and from the lateral lamina you have the tensor veli palatini muscle from the lateral lamina, that is cut to show the tube. So during swallowing the tube has to open, so which also tenses the palate. So that is why this muscle is also called as the dilator tubae. Okay. So coming to the functions of the auditory tube, so as it told you, it maintains equilibrium on either side of the tympanic membrane. So at rest it is closed, but when you swallow or yawn or sneeze, naturally what happens? It opens. The tube pops up so that the air pressure is not disturbed and the tympanic membrane is not retracted. In children it is somewhat horizontal. The tube is actually horizontal, whereas in adults it is oblique. So more chance of infections from your nasopharynx can spread to your middle ear. Okay, okay, so that is more common in infants because it is shorter and wider. So otitis media, mainly infections from your pharyngitis or from the nasal cavity through the auditory tube, can enter into your middle ear cavity, and this is more common in children because of its horizontal and wider nature. So excess mucus production in chronic sinusitis patients can also lead to blockage of tube. Okay, and you are able to see, you'll be able to experience what do you call retraction of the tympanic membrane as you ascend a hill, or when you are actually during a takeoff in an aeroplane, because the atmospheric pressure outside the tympanic membrane changes, so the tube get retracted. Only thing is you have to actually swallow air continuously, so that air will pass through the auditory tube and you can hear a pop sound with the tympanic membrane moving on to its original position. So chronic smokers also, what happens is damages the cilia in the tube, and a patulous tube is actually intermittent opening of the auditory tube, not only during swallowing or also what do you call sneezing, but also intermittently it opens and you can able to see associated increased heartbeat in case of this condition. Okay, so that is all for today, and we will continue the remaining part of the middle ear and the internal ear in the second part of the ear class. Thank you for your patient listening.